The French, Belgium, and Swiss GRAL group performed 2 trials in 2005 and 2014. The first one, we had a very wide indication of allogeneic stem cell transplant in first complete remission. And our conclusion on this trial is that the response to the first regimen, so induction regimen assessed by MRD, was the best predictors of the benefit of allogeneic stem cell transplant. And so with our 2014 trial, we moved to an indication of allogeneic stem cell transplant only based on N of induction and N of consolidation MRD. And what we were able to show is that the survival of the patient was better than we had before. We did not modify the DFS, but we were able to reduce by 50% the rate of allogeneic stem cell transplant in first remission for younger patients. So we think that one of the best criteria to decide to transplant or not is the early MRD response after induction or after consolidation. But the question now is there any subgroup or biological subgroup where transplantation could be of interest, whatever the MRD response? And so far we don't know, because there are now more than 25 subgroups of ALL that has been described. There are questions about KMT2A rearrangement, about pH-like ALL. We think our practice is to continue to take the decision on MRD, whatever the subgroup. But I think that this question remains open, and probably we should work on a collaborative study to show if there is a benefit or not. Because if you have few patients, you are limited in terms of power to prove if there is a benefit or not. But our strategy in the GRAL group is to base the transplant only on MRD, and if the patient achieves MRD negativity, whatever the context in terms of biology, we don't think the patient should be considered for allogeneic stem cell transplant.